My wife was telling me, says, we have a good life. You have a good practice. You're writing this book against the leaders of your field. You're going to be in danger. And I was like, my life is already ruined. Once I found out what we did, once I found out these things, once I found out the most referenced paper in our world of spine surgery is an unfinished preliminary report, I can't live with myself. I mean, I just can't.
If you like our show and want to learn more, please visit our website at peakwellnesshealth.com, which is linked in the show notes below, where you can gain access to a very simple 10-day body reset program that teaches you about diet, sleep, meditation, exercise, and guides you on how to lower blood sugar, lower blood pressure, lower body fat, and improve your biomarkers all in just 10 days. Additionally, you can find a body optimization program, which teaches you how to lose fat and build muscle. You can also find a link to schedule a one-on-one consultation with me. Hello, everyone, and welcome to Peak Health with Dr. Gupta. This show is for those who want to optimize their health and maximize their genetic potential. Imagine this scenario. You have severe back pain and your surgeon states you will need spinal fusion surgery. You trust him or her with that decision, but what you may not know is the procedure he or she has performed has little proven effectiveness. What is this procedure and how can we protect ourselves? Well, to answer this question, I'm ecstatic to have Dr. Ardavan Asli joining us. Dr. Asli is a board-certified orthopedic spine surgeon who received a spine surgery fellowship training at Harvard University. In addition to his private practice, Dr. Asli has been active in researching and developing cutting-edge treatments for osteoporotic and aging spines. Welcome, Dr. Ardavan.
Thank you. Thank you for having me.
Yes, I'm excited to have you. And let's start with a simple question. What is your specialty and what are the most common conditions you treat?
Well, I am orthopedically trained because they're orthopedically trained spine surgeons. So there are two ways of becoming a spine surgeon. One is going through neurosurgery, become a brain surgeon first, and then either do a fellowship or not, and then practice as a spine surgeon. The other route is going through orthopedic surgery, become an orthopedic surgeon first. Then you have to do a year of fellowship to focus on spine. And then after that year of fellowship, you can start practicing as a spine surgeon. So I did a residency in orthopedic surgery, became an orthopedic surgeon, board certified in orthopedic surgery. And then I did a year in fellowship and I've been practicing since 2002. So this is my 21st year of practice.
Okay. Somewhat familiar with the spine then, I would say. After
Sure.
20 years. Yes, 20 plus years. Okay. So what are the most common conditions that you treat?
Well, I practice in what we call the Greater Sacramento area. I'm not practicing in the university referral center, which is mostly trauma and scoliosis that they practice. So I treat pretty much the most common conditions of spine, which causes pain, neck pain or back pain. So if patient has neck, arm pain, low back, leg pain, they come to see me and I that's my job to treat that condition.
Excellent. Okay. And let's talk about spinal fusion. Why would somebody need this procedure? Is it because of pain? Is that one reason they would need this type of procedure? And what is it exactly?
Correct. So about great majority, and I'm talking about great majority of patients that they come to see me, they're suffering from pain. I'm talking about 90, well, almost I can say even 100%. These are the patients that they have had pain for some time. Initially, if the patient has pain, they go to the regular doctor refers them to a physical therapist. If that works, great. If it doesn't, then they get referred to pain management and they'll perform pain procedures like epidural injections or so. And if those fail, then their doctor send them to me to see if there's anything I can do for them. And of course, the first thing that I do, I obtain an MRI to see their condition. Now, if the patient has a pain that correlates to, let's say, a damaged disc that I see on the spine, because spine is a bunch of bones that are stacked up on top of each other. We call them vertebrae, separated by cartilage, cushions that we call them discs. And these discs are the structures in the spine that they get damaged and cause pain. So So my job, actually, I always tell my patient, my job is to avoid surgery. My job is to do whatever I can for the patient not to have surgery. That's my primary job, even though I'm a surgeon. That's what I'm trained to do. So let's say I go over the patient. I ask them what they've tried so far. If they've tried some procedures, probably didn't help them. That's why they're here. And they haven't tried certain procedures short of surgery that's available to us, then I'd recommend those. Let's say they tried those and those didn't help. Now they've tried everything short of surgery, then the surgery is the only thing that's left. So my job is to determine if I can find something on the MRI that can correlate or actually is capable of producing the pain that the patient is complaining about. If I do that, let's say the pain is in the distribution of a certain nerve, and I see that right around that nerve or that nerve comes from, if there's a damaged disc, there's a herniated disc that's pinching on that nerve, then I can say, at this point, what I see in the MRI and your complaints they correlate, they relate to each other. That means that if I go and fix that disc, more likely than not, patient's condition will get better. So the big question is, how do you determine if somebody needs surgery or not?
Right.
Well, there are two things that needs to happen. One, I should identify a problem that I think that's causing the patient's pain. So that's the first thing that I have to identify. A disc, most of the time, is a disc that's doing that. Two, a patient that has completed all the course of non-operative care and has enough pain that pushes him toward the next step would be surgery. Therefore, the decision for surgery is a patient's decision because they know how much pain they're in. The problem with my world is that that's the first thing that I would like to tell my patients. I cannot look at the MRI and tell them where the pain is coming from, because this is the concept that I want my patients to understand. Damage does not equal pain. If you have a torn disc, a herniated disc does not equal that patient should be suffering from pain. No, as a matter of fact, great majority of the discs that are damaged or so, they don't hurt. We don't understand what. We don't understand. We don't get it.
Right.
It's a small portion of the people that actually hurt. So it's not the damage that causes pain. It's the inflammation that causes the pain. And we cannot see the inflammation, or we cannot detect the intensity or extent of the inflammation. As a matter of fact, in the book that I wrote, there's a part that I refer to is that what makes spine surgeries difficult is that we cannot say where the pain. For example, you can have a patient that has back pain, and you look at the MRI, and there are two discs next to each other. One of them looks horrible. The other one, maybe a little bit abnormality, one small little tear or so that doesn't look bad at all. Well, it will turn out that it just doesn't look bad is the source of the pain, and the one below it that was looking horrible is not causing the pain, basically. And that's why sometimes spine surgery gets a bad name, because sometimes you do the bats or you do the surgery, and as spine surgeons, we want to do the smaller surgery, so we tend to operate on the worst looking discs. And most of the time, the worst looking disc is the source of the pain. So I want to make that clear.
Right.
But sometimes you do the surgery, patient wakes up and say, I'm no better. I still have the pain. Well, that's the problem. For example, I'll tell you a story.
Sure.
About 10 years ago, I had a patient. It was a nurse at my hospital at Sutter Roseville. She came to me. She was complaining about neck and arm pain. She had a very bad disc damage, deteriorated at the level of C5-6. And I had a casual attitude, not exactly casual, but I had this attitude that, don't worry, no problem, I'll fix you. So I did the surgery at C5-6. Patient woke up, came to my office after the surgery and said, I still have that pain. And I was like, oh my God, what am I going to do? I myself sent the patients to a couple of the surgeons in Sacramento that I trust, that I like. And they all said the same thing. Dr. Asli did the right surgery. You're healed. We don't know. Sorry. This is it. Sorry. You're going to be stuck with the pain. So, and the patient stuck with me. She believed in me. So I followed her for about a year. After a year, I told her, I said, there's another disc below it that doesn't look bad at all. I mean, not at all, but there is a little tear. That could be the problem. But I cannot talk about another surgery. God forbid, if I do the second surgery, you're not better. Now you've had two surgery. You're still in pain. I won't forgive myself.
Yeah.
But that could be the problem. You need to make that decision. She came back a month later and says, I can't live like this. I'm going to take my chances. That's exactly what she said. I'm going to take my chances. I did the surgery on the disc below and all of the pain went away completely. So that just tells you that how difficult spine surgery it is and how difficult our job is to kind of chase the pain. See, the problem is that when you're doing the surgery, patients sleep. They cannot tell you that, you got it, doc. That's it. That's where it hurts. It's not like a shoulder surgery. You know, there are torn ligaments. You go fix them all together.
Now, I'd imagine you mentioned pain as like more of a relative indication, but I'm sure there's absolute indications for spinal surgery. For example, trauma or some kind of spinal instability or deformity or something like that, or if you have motor nerve compression, correctly, you have weakness in a limb. Like you're like, okay, this is a definitive thing. You can see it. It's obvious. You have to do this procedure. Is that correct?
Correct. And those conditions are not super common because what brings the patient to the doctor is the pain. If the patient has tumor at some point, somebody detects it, that's a different story. I mean, if there's a tumor or something that needs to be fixed, and most of the tumors in spine, they get treated by radiation or chemotherapy or so. But sometimes you're right. Sometimes the patient comes in and says, I can't walk very well, or there's been change in my hand movement, fine movement. And you get an MRI and see that, there is a lesion, either tumor infection or a disc that's compressing the spinal cord. In that condition, yes. Even though, for example, patient is not in a lot of pain, we have to do surgery. We have to get the pressure off the spinal cord. I'm sorry. Why? Because spinal cord is not a cable that connects brain to rest of the body. No, it's actually an organ. It's a computer. So it doesn't tolerate compression very much. And there's a lot of reserve. So what happens is that there is a compression, spinal cord looks kind of a scarred, and you're good. And then you fall off a cliff. By fall off a cliff, I mean, you go down within a year or so. So the cliff is not like immediate paralysis. No, the cliff, we're talking about a year or two window. And spinal cord doesn't have too much capability of recovering itself. So as soon as we see that the function of the spinal cord has been reduced, and we check that by balance, by repetitious movements that actually they coordinated by the spinal cord, then we tell the patient that you need surgery. And actually, I have patients like this that I tell them, I said, look, I'm telling you that you need this big surgery. I'm going to put you through a lot of misery. I'm going to go from the front, back. You're going to be in hospital for 3-4 days. You're going to have pain after that, surgical pain after that. And you're going to see no benefit. You're going to see nothing. But it's necessary. Why? Because the most important benefit of the surgery you'll never see, which is stopping you from getting worse. And that's a conversation that I have to have with some of my patients.
Okay. So basically, in essence, there's absolute indications. There's relative indications. The relative one mostly is the pain. And as you mentioned, it's like an art, really, trying to figure out exactly if the MRI correlates to their pain, which disc is involved, which spinal level. What is this procedure that you do most commonly? And I know you wrote this book about it, and I'd love for you to talk about it here. Like, what is this procedure you do most commonly, and what are some of the shortcomings of this?
Procedure that we have available for us is a surgery called fusion surgery. So let's say we get an MRI, we see a disc that's not looking good, it's deteriorated, it's torn, it's herniated. The location of the disc correlates to where the patient's complaining about pain. That means they correlate. So that disc is more likely than not is a source of the pain. Then the surgery that we have is that we take the patient to surgery. We approach either from the front or the back and take the disc out completely, put a spacer between the two bones where the disc was before, and basically turn the two bones into one bone. We call that fusion surgery. And that works well.
This is what you do with the patients in pain, same procedure that you do. Okay.
Correct.
Got it.
Correct.
Okay.
The problem is this.
Go ahead. Yeah, please.
Sure. The problem is this. Well, we started doing these surgeries right around 1970s, 1980s. The problem was that, well, when you try to create bone where there was no bone before, well, sometimes that doesn't happen. And that's part of patient's biology. We can do good carpentry, but what happens after, the patient has to heal all of that and turn the two bone into one bone. Well, sometimes that doesn't happen. And according to the paper, that happened about 1 out of 4 patients. So 25% of the times, which is a large number. In these situations, patient would get better after surgery, but then 4 or 5 months after surgery, the pain would return and it would get actually worse because now you have all that surgery there. So we try to see how we can solve this problem, how we can increase the fusion rate so more people heal and less people with a failed, what we call failed back syndrome or failed surgery, basically. Well, being a subspecialty of orthopedic surgery, spine surgery being a subspecialty of orthopedic surgery, we had already learned quite a bit from fracture fixation. We knew to heal the fractures, we applied a principle called rigid fixation. We would hold the two bones together by screws and plates. We would put the bones back together with surgery. We would put a thick plate next to the bone and shoot some screws above and below the fracture to hold it all together. We knew that the rigid fixation was the key. So we applied the same exact technology to spinal fusions. Well, when it came to spinal fusions, right around 1985, a French surgeon, 2 surgeons figured out how to put a very large screw into the backbone, the vertebral bone. We call these screws pedicle screws, and this is the example of it. So these are the screws that get inserted from the back to the front through this column of bone we call pedicle, basically. And we call it pedicle screw. So in every vertebrae, you put 2 screws, one on each side. And if you want to fuse, let's say 3 vertebrae together, you put screws in consecutive bones. And these screws, they're very thick screws, but at the bottom where the head is, there's a tulip that can accept a rod. So you put as many of these screws that you want, as many levels that you want to fuse, and then you put a rod and you connect them all together. And there's a bolt that comes in over the rod and basically secures the rod to these screws. And they all screws basically connect to each other. And this way we immobilize that segment of the spine that we want to fuse. We call this instrumentation. Well, this is the problem. Right around 1985, like late 80s, when these screws became available, there were really bad results. At some point, there were about 7,000 lawsuits against the manufacturer of these screws, a company named Mordanic, which later became Medtronic. As a matter of fact, there was some investigation by the United States Senate. Orthopedic surgeons, the leaders of the orthopedic surgery and neurosurgery actually went to Congress and they had to testify. Well, right around 1993, a surgeon called Dr. Zdeblik published a paper that he was the only author. And he said in his paper that these screws work beautifully. They work better than anything else. Patients, so you have 2 groups of patients. One group did not receive the screws. The other group received the screws. And he was able to show that the people who received the screws did far better in terms of returning to function and pain management after the surgery. Well, that was a green light for us to start using these screws. And by late 1990s, the use of these screws had become routine in fusion surgeries. To this day, right now, every time I do low back surgery, I put these screws. Every time I do neck surgery, I put these screws. And that's what we do right now, except there is a big problem. And this is what happened. When I was developing a device for osteoporotic vertebrae. So when I was developing that device, I said, I got to go back and look at the literature. I got to see, there was a problem that I faced. I said, let me look at the screws, see how did they solve that problem or what's going on? Well, I found out that the screw has the same problem. I said, wait a minute, there's a problem right here that nobody talks about. Let me go look at the literature, see what's going on. And the more I read the literature, the more surprised I got and the more fascinated I got because it was just shocking what I found in literature. What I found, so I told you earlier that Dr. Zdeblik published a paper in 1993 that made basically all these screws, using the screws, standard of care. Well, I found 6 multinational, multi-center papers that was published from 1997 till 2003 that said these screws don't work. They do not increase fusion rate and they do not improve outcome. If anything, they increase complications and nerve damage or so. So if anything, it was actually worse using those screws. I was like, wait a minute, what is going on here? This doesn't make sense. So I got more alarmed. So I said, well, let me go back and look at that paper in 1993, because here is 6 papers says it doesn't work, multi-center, multinational, some of them award-winning, and they were all published in Spine Journal or Spinal Journal. So they were all legit articles. They got published in our own journal. So I said, let me start questioning the paper in 1993. Well, the first thing that I found was just drop my jaw. The first thing, if you Google right now, and I invite your audience to do this, put in Google Zdeblik Spine Fusion article. You will see that this article that was published in 1993 by Dr. Zdeblik, as of today, has been referenced in 1,126 articles as of today. This paper by Dr. Zdeblik is the most referenced paper in the entire world of spine surgery. Everything that we do today tracks back to this one paper. But the first thing that you will notice is that this paper was published as a preliminary report. I spent 2 years to see a follow-up report or the follow-up study, and I never found it. Eventually, I asked one of the professors from Maine universities, and he said, that study was never finished. It was abandoned in the middle. That preliminary report is the only thing that we have. I was like, oh my God, my jaw dropped when he said that. I was like, wait a minute, I got to do a little bit more study. This doesn't make sense. Then I found that, and this is a common knowledge. This information that I'm telling you is in Google, and all the investigations were done by United States Senate. So Dr. Zdeblik publishes this paper in 1993. By 1996, those lawsuits, those 7,000 lawsuits that I was telling you, were disappearing because of this paper. Then in 1996, Dr. Zdeblik started getting paid from the company that was manufacturing those screws. By 2003, he had gotten paid $34 million. That much. And I was like, oh my God, this is pretty bad. But wait, they got 10 times worse. Then the same company, Medtronic, put Dr. Zdeblik in charge of another very important study about bone graft substitute. Now, originally I said that when we do fusion surgery, we're trying to create bone where there was no before between the two backbones. Well, to do that, you have to get bone chips from somewhere. You have to get the bone chips and put it between the two bones so it will turn into a solid bone. Well, most of the time, you have to get this bone chips from hip bone. That when you touch your side, that hip bone, we call it iliac crest. Well, the problem with that is that every time we got bone from there, well, that area that we took the bone from started hurting. So that we create a problem by just harvesting the bone. So we were trying to look for alternatives. Well, right around early 2000s, Medtronic came out with a product called bone morphogenic protein. It's a hormone that we all have. When you break your bone, you excrete it, and that's how you heal the bone. Well, they isolate that product and they duplicate it in the lab, and it comes as a product, as a sponge. Well, Medtronic put Dr. Zdeblik on the study for the BMP, and Dr. Zdeblik published those papers. There were 2 papers that published right around mid-2000s. Like one of them was published in 2004. This time, Dr. Zdeblik got caught falsifying his results on those tests. By who? By United States Senate. As a matter of fact, it was the conclusion of the United States Senate panel that investigated this, that paper that Dr. Zdeblik published in 2004 was not written by him, was written by the company.
Wow.
So
Okay.
I was like, wait a minute. There are 6 multi-center, multinational papers saying, some of them award-winning papers, saying that these screws don't work.
Right.
And then one paper written by a guy who got paid millions of dollars from the manufacturer, and he got caught falsifying his results on a subsequent study. What is going on? That was the biggest question in my head for 3 years.
Ardavan, just a couple questions on this. Now, when you say don't work, now you're talking about specific indications, and this is for pain purposes, correct? Okay,
Correct.
so because as we discussed before, there's some absolute indications for the pedicle screw and the lumbar fusion. And as far as those go, this screw and this technique is potentially morbidity saving type procedure.
Correct.
So, okay, so
I want to make
we're focusing specifically on pain and lumbar fusion and improvements of symptoms over X number of years. How many years do they follow up patients?
Which study? The one in 1993?
There's a Zdeblik one you mentioned. How many years?
Right. Well, actually, I'm gonna talk about that. That's a very important question that you just asked. But let me explain something, so I want your audience to not get confused.
Absolutely.
Now, I'm telling you what we have in our own literature, the spine surgery literature that I know very well. The literature says that this fusion surgery works. We've been able to show with research that people who had fusion surgery, as opposed to people who did not have fusion surgery and they elected to do nothing but physical therapy or chiropractic care, they ended up with a better outcome. So we know that the surgeries that we do work.
Okay.
But also the research says that addition of these equipment and making the surgery a lot more expensive does not add any benefit to the eventual outcome. That's the
okay.
question.
So what equipment? What equipment specifically?
The screws.
The screws itself. Okay. So then what do you use? What's the alternative?
Well, the alternative is not to use the screws, as a matter of fact. Just leave the patient just in the brace, basically.
Oh, so it's a brace, but then you said you are operating though. You're operating, but you're not using the screws. So then do you replace the disc, but you don't use the screw? Is that what you're basically doing?
Correct. Exactly. Okay. So this is the surgery. You go in, you take the disc out, you put a spacer packed with BMP or bone graft. Then you have options for going through the back and put the screws or not putting the screws. That's the thing. And right now, the standard goal, the standard of care is to go back and put the screws in. And that's what we're talking about here.
Are you struggling with reaching your health goals? Do you feel like you need extra help to achieve your desired level of wellness? Well, we're here to tell you that you're not alone. Our website at peakwellnesshealth.com, which is linked in the show notes below, offers a variety of resources to help you on your journey towards optimal health. One of the most popular resources is the 10-day body reset course, which is designed to teach you about diet, sleep, meditation, exercise, and how to lower your blood sugar, blood pressure, body fat, and improve your biomarkers all in just 10 days. Our program is comprehensive yet easy to follow, and we've seen amazing results for those who have completed it. But that's not all. We offer a body optimization course, which teaches you how to lose fat and build muscle. Our program is tailored towards your individual needs and goals so that you can be sure that you're getting the most effective guidance. And if you need even more personalized support, we offer one-on-one consultations. During these sessions, we'll work with you to create a personalized plan that takes into account your unique circumstances, preferences, and goals. Visit peakwellnesshealth.com today and take the first step towards achieving your health goals.
It makes logical sense to me that if you have a spine that undergoes torsion, that twisting, bending, and you have something like screws and bolts that are holding it in one place, they're going to eventually come undone. And I think it makes logical sense. Obviously, we don't base what we do as physicians on just pure logic. We look at data, controlled trials, and things of that sort to make sure that what we're doing actually works. But what you described to me, I guess, at least on a kind of a logical level, it does make sense.
That's exactly. And I'm going to get back to what you just said, that you're right on the exactly. And that's what I had to think about 3, 4, 5 years over. What is going on here? But let's go back to that question that you asked about Dr. Zdeblik. Let me explain to you something.
Sure.
I went back and dug deep on that study. So this is the amazing part. Dr. Zdeblik finished his training in 1989. Okay. So 1989, he finished his training and he went from somewhere Baltimore to Wisconsin, Madison, Wisconsin, where he's practicing right now. And he's the chairman of spine surgery in the University of Wisconsin right now as we speak.
Right now. Okay.
Right. So 1989, he finished. Okay. Well, let's move back from that study that was published in 1993. You can't just publish something. You cannot just send a study to the newspaper or article and they put it in the next thing. No, you have to go through peer review. You have to be accepted. Even if they accept it right now, they won't publish it till about few issues, like few months down the road.
Right.
So let's say if he got published in summer of 1993, that means that he finished that study in 1992. Sometimes toward, let's say, I give him credit. Let's say he went through fast track, sometimes toward the end of 1992. Well, you can't just do surgery and then publish paper. You've got to follow the patients.
Sure.
He stated that he followed his patients for about a year. So, okay, so that goes from 1992 till 1991. Okay. So he finished his training in 1989. That means he had only 2 years to do all of this study and the first 2 years of his practice. So the first 2 years of practice to do this complex study and publish the paper that came quintessential anchor point for an entire specialty. It just doesn't make sense. He didn't have enough time. There was just not enough time. And that's why the study was published as a preliminary report. The question is why he didn't finish it. What happened? We need to know that.
And you mentioned he's a chairman of the orthopedic spine department, and he's also caught fraud of one of his studies. So how does that work? I mean, how does that even work?
I don't know. Don't ask me. I have no idea. And that's, to be honest, that's what I wrote in my book. That's a scientific norm. There's a scientific norm that if you ever get caught falsifying a result or altering data, that automatically annihilates your entire study.
Yes.
So if he gets caught, and he's been caught by United States Senate in 2004, that means automatically that paper, the only paper that says these screws work, that's been referenced in 1,126 articles as of today, it's nulled automatically.
Okay. So this is so interesting. So really what we're talking about here is, I'll just break it down. Number one, we're talking about a relative indication for surgery. There is a lot of data suggesting that physical therapy and surgery over a longitudinal period have the same endpoints. Like for people with certain types of back pain, all types, I'm not sure of, but certain types of back pain, there is some data that suggests that. There's certainly data that suggests there is some surgical benefit to helping these people. What you're proposing here is, hey, look, let's step back. Let's look at these pedicle screws. Let's look at these rods. Let's really determine whether we're really helping these people putting these in place versus just basically removing the disc and fusing the spine without the use of these devices. And so you can make it a less complicated surgery. The healing potentially would be what? The same? Would be the same, and outcomes would be made potentially better. So why is it not done? Why do people use these rods and screws? And why not just do that?
That's the thing that I was going to get to. That's exactly where you mentioned. Now, before we go forward, I want to make one thing clear for your audience. Actually, we can discuss which one is more effective: physical therapy, chiropractic care, surgery, and stuff. But this is basically what it comes down to. This is what I tell my patients. You go as far as you can go, till the point that you can't go anymore. That's the point that you've had chiropractic, you've had physical therapy, and you can't go any further. That's when we do surgery.
Sure.
So
last resort,
right. And I always tell my patients, they always come to me, they have questions. What's going to happen to me? Is there going to be damage above the fusion? We heard that if you fuse one area, that puts pressure on the disc above. And we heard that your back gets stiff. I say, look, this is how it goes. You go as far as you can go till you can't go. Then we have to do surgery. And what comes after, it is what it is.
Yeah. Okay.
And that's the basic reality of spine surgery.
So now let's focus. Oh, actually, one last question before we move to another topic. What do you think the reason is to maintain this practice versus changing it? Is it just, I know as a physician myself, I know it takes time and understanding for doctors to make change. Things don't happen overnight. I think we live like almost a decade in the past in some ways. Like that's how we practice.
Right.
It's you just have to, people have to be like, have a understanding of what is new, try it and practice, see other people doing it, then slowly it becomes part of their routine. But do you think that is it? Do you think there's corporate interest involved here? Do you think it's reimbursement? I mean, what is the issue?
Everything that you told me went through my head, and it took me 3 to 4 years to find that answer. And I did find the answer. And this is the answer. We, as orthopedic spine surgeons, we became orthopedic surgeons first. We learned how to fix bones, and we applied that same exact principles to spinal fusions. And I'm here coming out saying that we should have never done that. Spine surgery was never meant to be a subspecialty of orthopedic surgery. What worked in extremity surgery does not work in spine. And I'll give you an example. This is just one example.
Right.
Concept of rigid fixation works in extremity because you can eliminate gravity. Either the upper extremity is in a sling, or when you do the leg surgery, you put them on crutches and lift them off the ground. You cannot eliminate gravity in the spine. The second that patient gets up, that construct is under tremendous amount of load.
Right.
And so we have to have a device that can flex and dissipate that energy as opposed to cut the bone off and everything come out.
Right.
That's the point. It's no different than building a high rise in San Francisco or earthquake zone. We've been able to build these huge high rises, Burj Khalifa, Taiwan Tower, San Francisco. Why? Because we found a way engineering that we can make these buildings flexible. It can swing back and forth. And if there's an earthquake, it can dissipate the energy. I remember I was being a chaperone for my 5th grade daughter about 3 months ago. We were in San Francisco in Marine Headlands, and the park ranger that was teaching the 5th grade, they were discussing about building the bridge. She turned around, told a class of 5th graders, about 25 5th graders, said, kids, remember, flexible is stronger. Flexible is stronger. And I'm like, oh my God, this is a 5th grade kids. This is a 5th grade physics. And somehow I cannot let my colleagues to understand that that's the way we should be going. And actually, I tell you right now, we're going in a completely the opposite direction. Right now, what they're doing, they're adding more rods. Now they're actually promoting, instead of 2 rods, add 4 rods to make it even stiffer. I'm like, no, it's the other way. So
it's interesting is in orthopedics itself. I mean, the bone is stronger when it's flexible, right? People think the bone is just a rigid structure that's there for protection, for musculature attachment, but it's an active tissue. It has to flex. It has to bend. And if it doesn't do that, you can develop fractures. And many people that have osteoporotic bone, that have history of fragility fractures and things of that sort, is because their bone is overly rigid. People that take bisphosphonates, and over time, their bones break because it's overly rigid. It's interesting that orthopedic surgeons know this as a surgeon, but then it doesn't translate to this particular procedure itself.
Now, you got to understand that there are 2 groups. When I say these 2 neurosurgeons, they're like, yeah, you're right. You're absolutely right. As a matter of fact, I invented a device and I presented in Congress of Neurological Surgeons, and I won the Innovation Showcase in Congress of Neurological Surgeons in 2015. But when I talk to the orthopedic surgeons, orthopedically trained spine surgeons, no, screw is it, and that's it. I know.
So this is like a neurosurgeon / orthopedic surgeon difference. Like if you went to a neurosurgical spine surgeon, they would treat you differently than an orthopedic spine surgeon.
Well, I'm not sure. No, not now, because the standard of care is the same to use these screws. When orthopedic surgeons came up with these screws, eventually at some point, neurosurgeons said, fine, we'll learn what you did. And then we became kind of warm. So now
Okay.
every time you do fellowship, you have neurosurgeons and orthopedic surgeons trained together.
Okay. So,
But
okay, go ahead.
But when I explain it to them, neurosurgeons get it and say, you are absolutely right. But when I explain that same concept to orthopedically trained spine surgeons, they're like, no, no, rigid fixation is the way to go, because they've been brainwashed in their training by fracture fixation that rigid fixation is the way to go. It's like the way I explain it in my book, and I want to let your audience know, is this. It's like going from Newtonian physics to quantum physics. Newtonian physics, if you want to build a house on Earth, you can use Newtonian physics. But if you want to build lasers or shoot a spacecraft to space, the Newtonian physics is not enough. It's not enough to explain the principles. You need something called quantum physics. Same thing's happening here. The basic carpentry that we use in long bone fracture fixation and extremity, basic carpentry does not answer principles that needed for spine. Why? Because the rotation, the motion of the vertebrae in spine is a rotational motion. The vertebrae doesn't slide back and forth, doesn't slide up and down. It rotates. So when you put that screw into the vertebrae, the screw has to stop rotation. Well, the screw is not a device to stop rotation. The screw is a one-dimensional device. It's for pull-out.
Right.
So every time you have a screw, we test it for pull-out. Every paper, every biomechanical literature that's been published, they test these screws in pull-out. Well, inside the body, they have to stop toggle. So the screw fails in a plane 90-degree off to the plane that actually is made to work.
Now, have you seen in practice, in your experience, have you seen failure? I mean, you've seen people come back with the screws actually coming loose and you have to reposition or what that happens?
Absolutely. Absolutely.
Okay. So that's it's an understood common complication of this procedure. You get that often. Okay.
Oh yeah. That's a very well known.
Okay. Okay. Well, I mean, this is fascinating. And it sounds like the reasons this are happening, one, potentially it's just maybe a understanding of the spine and a specialty. Maybe it shouldn't be a neurosurgical or a orthopedic surgical specialty, but it should be its own specialty. It sounds like there's corporate interest here. It sounds like there is just habit formation here. There's a lot of kind of things going on here. But I really applaud you, Ardavan, for trying to make change for the benefit of the patient's health. Because I mean, the truth is, you're not benefiting from this. It's not like you get paid more to operate. You get paid more to put more devices in the patient's back. So it's not like you're benefiting that way. You wrote a book about it to educate folks. You're not making, it's not like books will make you millions. Like we know that. That's just not the case anymore. You're just trying to educate people and help them understand, hey, look, there's a different way to think about this. You should consider these options. So I really applaud you for that. And I appreciate that.
Let me tell you, my wife was very scared. My wife pleaded with me not to write this book. My wife was telling me, says, we have a good life. You have a good practice. You're writing this book against the leaders of your field. You're going to be in danger. And I was like, my life is already ruined. Once I found out what we did, once I found out these things, once I found out the most referenced paper in our world of spine surgery is an unfinished preliminary report, I can't live with myself. I mean, I just can't. I told my wife, it's like, my life is already ruined. I cannot sleep at nights.
Yeah.
I have to do something. It's my duty. And I tell people, I say, it's your duty to read this book to find out what these corporations have done. And I'll explain to you why. And there's a big reason why this has happened here. And this is the reason. When we go, and I just want your audience to understand that I don't just talk the talk. I go fight the fight. I go to these conferences and I get up and I raise these issues. Nobody wants to listen to me. One time in 2016, in American Academy of Orthopedic Surgeons, I got up and I said, we have created an alternative matrix for ourselves. We come to these conferences and you guys, so-called leaders of the field, you show your best x-rays, best outcome, best MRIs. And we come to these conferences and we get this impression that these surgeries work great. Everything's worked great. And then we go back to our communities and do surgery on our patients and they end up in pain management and paying for the rest of their lives.
Yeah.
Because nobody presents their complications. Why? Because as soon as you show a bad result, a bad surgery, the first question everybody asks, what kind of a screw? What company did you? And the companies don't want you to show that kind of. So it's the companies that have put this environment or surrounded us with this environment that surgeons don't show their bad results. And that's how you learn.
Yeah.
So we have this wrong perception and that we're doing great. Meanwhile, our patients are in pain management for the rest of their lives. And
well, fundamentally, you're thinking about the patient's best interest, which is it is really the most important thing, and that's we all are focused, and we should be focused on that as the primary motivator for us, and not other types of things. So I applaud you for that. We have some remaining time. Maybe we could talk about, well, one thing I do want to mention to the audience here is if you haven't listened to Doug Lucas's Bone Health podcast, please do so. Just do, it's on the Peak Health podcast list. Look up Doug Lucas, talks at length about bone health, how to make sure that you protect your bones. In essence, nutrition, decreasing stress, inflammation, taking the right minerals, vitamins. The basic functional medicine types of things are important, but there are some nuances to this. So please listen to that if you haven't already. The other thing that I just want to talk about are non-surgical ways to protect your spine and the causes of pain in and of itself. We spoke about this a little bit before the podcast started, but you mentioned that just your job is one of the main drivers of spinal pain. Like if you're constantly looking down or you are lifting heavy weights or whatever, over time, that is with the repetitive motions, that's going to cause pain. So number one is consider what you're doing and how to consider ergonomics, consider biomechanics. And let me ask you this, Ardavan, what are some ways that people can protect themselves so they don't need spine surgery? They can keep their back healthy.
That's a kind of a difficult question because why? Because everybody's so different, we have different back strengths. You cannot look at this disc and say how good or bad it is. I have patients that have thick disc. I have patients that have very narrow disc. And not only that, in a molecular level, you don't know how heavily cross-linked their collagen is. So they're so complex in terms of saying who has a bad back, who has a good back. But this is what I tell my patients. It all comes down to the attitude. What I tell my patients is that you don't tell your back what to do. Your back tells you how you can live your life. So if you've started having some back issues or so, just try to figure out what is causing this, and you got to pull back on that. For example, I have a lot of patients that they come in and they want surgery, and I tell them, you don't need surgery. You need a new job, because their job is like some heavy lifting, like a welders, lifting people. Say, you need to get yourself another job. That's what you need to do, not getting surgery, because you keep lifting stuff all day, and that's really what's hurting your back. So those activities are very important. If you are doing exercises that's hurting your back, you need to change your routine. You need to do exercises that doesn't put pressure on your back, like doing overhead weights or so. So that's what I tell my patients, that you need to listen to your back. And that attitude adjustment is the most important thing. For example, I have some patients that they're self-employed. They're barely making it. I have so many patients that are gardeners. They are landscaping business. And I tell them, you need to hire some young kid to do the heavy lifting for you. And they're like, I can't afford it. I'm like, you don't understand. The money that you're spending on that kid is the best money that you can spend. Why? Because one thing, You can avoid the surgery. Two, it lets you work longer. Otherwise, if something happens to your back, you can't work anymore, you're done. Everything is gone. So those are the things that back pain is a very difficult, troubling symptoms. And the problem with back pain is this: patient is not sick, so they don't look bad. So people always question you, hey, what's wrong with you? Hey, you're lazy, you don't want to do this. Meanwhile, you have a knife stuck in your back, and patient is the only person that can feel that. So it is a very difficult situation. So if I have to say one thing that I want to tell your audience, the most important thing, the most important thing where they have to start is an attitude change. And they need to understand that they don't tell their back what to do, because everybody wants to keep on with the activities they were doing. Let's say they play golf. I'm not going to quit golf. Do something, tell me something so I can do this and keep going with the golf. Or I'm not going to do this. That's my life. That's like, no, you have a new life now.
Yeah. And oftentimes it's not just like you can get back to it, but people, these repetitive motions will cause pain. But then if you take time to heal and rest and relax, and maybe you have spasm and things like that, and that goes away, you can get back to it. But as you mentioned, posture, ergonomics, like where you're bending, you're lifting, you're doing it correctly. You've got the proper core muscular strength. You've got the proper paraspinal muscles. This is why I think, and I stress on this podcast a lot, like weightlifting, muscle hypertrophy. These things are so important because it maintains your frame and it protects your bones and it protects your spine. As you mentioned, prolonged sitting, make sure your weight, you maintain a healthy weight, quitting smoking, manage your stress. These are all things that are very important. Not drinking too much alcohol, like things like that. Very important for just maintaining your overall health, but they will translate to your bone health, your spine health as well.
Right.
And this was phenomenal. Thank you so much for this information. And if people want to learn more, they want to see what you do, how do they contact you? How do they get more information?
Sure. Thank you very much. My book, as I said, it's Corporate Spine. That you get it in Amazon. There's only $25. And in the first 4 chapters, I try to teach my patients what we go through as spine surgeons to evaluate the patient and why we recommend certain treatments for what type of patients. Because I really think spine surgeons haven't done ourselves a favor to try to teach public what we can and what we cannot do. And that's what I've tried. I've put 20 years of what I've learned in spine surgery into easy reading. See, it's not written for another doctors. It's written for patients. And I've tried to teach my patients through stories of my patients. So it's an easy read.
Excellent. Well, we'll put that in the show notes below. Thank you again.
Thank you.
I hope you enjoyed this podcast. And if you did, please make sure to hit the subscribe and the like button and leave a comment about what you'd like to see on our future episodes. Just a reminder that this podcast is for educational purposes only. It does not substitute for professional care, nor does it constitute medical or other professional advice or services. If you're looking for medical care, please seek a qualified doctor or medical professional. For more information, or if you'd like to check out our programs, please visit our website, peakwellnesshealth.com. That's peakwellnesshealth.com.